Okay, great. Thanks to everybody for joining. Good afternoon. Really appreciate you joining us for our webcast on promoting lipoprotein A awareness and testing for risk identification through outreach and teaching. I'm Dr. Seth Martin from Johns Hopkins, and it's my pleasure to introduce today's speaker, Dr. Navid Radfar. Navid Radfar is a third-year internal medicine resident at Rutgers, New Jersey Medical School and an incoming cardiovascular disease fellow at his home institution. He has focused academic interest in lipidology, preventive cardiology, and implementation science aimed at improving cardiovascular risk detection and management. Dr. Radfar spearheaded a system-wide lipoprotein A screening initiative across Veterans Affairs healthcare sites in New Jersey, with recent expansion to University Hospital, the primary teaching hospital at Rutgers, NJMS. His work centers on translating emerging lipid science into real-world clinical practice, with particular emphasis on LPA-mediated cardiovascular risk, population screening strategies, and post-identification management pathways. In addition to his research efforts, Dr. Radfar is part of the clinical education track at NJMS, where he is actively involved in teaching medical students and junior residents. He also serves as chair of the resident wellness and as an ombudsman for the residency program, reflecting his commitment to mentorship, education, and physician well-being. So before I turn things over, just a quick housekeeping note. This is not a CME session. This is for your own general knowledge. We'll be holding a short Q&A session at the end of the presentation. We'll try to leave like 5-10 minutes for Q&A. So if a question comes to mind at any point, please check the bottom of your Zoom window and use the Q&A feature to submit it so we have those ready. And we'll keep a running list and get to as many as possible before we wrap up. So thanks again to everybody for joining. Without further ado, the floor is yours, Dr. Radfar.
Thank you so much, Dr. Martin. Thanks for having me. I'm so excited to be here and talk about lipoprotein A awareness and testing for risk identification through outreach and teaching. So I don't have any disclosures. And so some learning objectives today, we're going to describe the pathogenicity and clinical relevance of LPA, understand how to interpret results and utilize risk stratification, apply guideline-based strategies to interpret LPA levels and refine cardiovascular risk assessment, identify current and emerging therapies that modify LPA or reduce overall risk, recognize implementation barriers and integrate scalable workflows to improve LPA screening and preventive care, and translate LPA detection into precision preventive cardiology using real-world QI evidence. And so just an overview, we'll briefly describe the pathogenicity of LPA, cardiovascular risk and epidemiology, screening, guidelines, disparities, current and emerging management strategies, implementation science and quality improvement, and future directions. So first we'll get into the pathogenicity. So the question begs, what is LPA? So the dirty summary of it is it's an LDL-like particle, but the key difference is it has this ApoA moiety, covalently bound to ApoB and oxidized phospholipid. That's what makes it different from LDL. And so what exactly is ApoA, right? ApoA is this domain that contains many of these repeat Kringle structures, and these share homology with plasminogen. So why is that important? Because this shared homology makes LPA very prothrombotic. It can interfere with fibrinolysis, and it competes with plasminogen for binding sites on fibrin and endothelial surfaces. And in doing so, it inhibits clot breakdown, hence its antifibrinolytic effect. What else can it do? It's very pro-atherosclerotic. So LPA binds to macrophages and causes foam cell formation. So you see here on the left side, this is atherosclerosis from the early stages. All the way to the right here, an unstable plaque on the right. And LPA tends to accumulate in higher amounts in other lipoproteins. And it has been found to be more atherogenic than LDL on an equimolar basis. And part of its triple threat is that it's also pro-inflammatory. So LPA is the preferred carrier of oxidized phospholipids. And these oxidized phospholipids on LPA can activate endothelial cells, macrophages, and monocytes, increasing cytokine release, adhesion molecule expression, and monocyte recruitment into the arterial wall, again, promoting this vascular inflammation and plaque formation. And so most people only need to be tested once, and we'll get further into who gets screened. But as you can see here in this figure, this is the global distribution of LPA, where over 80% of people are going to have normal levels. And truthfully, may not even be a significant factor. But there's a lot of variability within disease states and even within ethnicities of people. But looking at the larger population, 80% of people will likely have normal levels. So why do we care about LPA? Genetics. So it is the most commonly inherited form of dyslipidemia, affecting 1.4 billion people worldwide, with LPA levels above 50 milligrams per deciliter. And in this case, it's also very, very undertested. The triple threat, like we discussed, is atherogenic, pro-inflammatory, and prothrombotic. Also, the risk associated with it. It is independently associated with coronary heart disease, peripheral arterial disease, and calcific aortic stenosis. And lastly, treatment. As of right now, there is a need for intervention given lack of dedicated LPA-lowering therapies. So next, we'll go into cardiovascular risk and epidemiology. So, question is, if LDL is low or normal, why do you care about LPA? Why screen someone for LPA? So a recent observational analysis from participants from the MESA study who were followed for about 13 years demonstrated that here in the second row, when LPA levels are high and LDL is optimal, there is still some type of cardiovascular disease risk. If anything, it's significantly increased, suggesting that LPA and LDL, again, exert independent risk to patients. And this is substantiated here in this meta-analysis of 6 placebo-controlled statin randomized clinical trials showing that in statin-treated patients who achieved the lowest LDL concentration in quartile 1, you see here, in the setting of an LPA that's above 50, which places them at increased risk, there was still a 38% increase in ASCVD risk when LPA was high and LDL was controlled. So this is suggesting that even when you control for LDL levels, the LPA risk won't be fully offset. It still exerts some type of risk, some residual risk, despite aggressive LDL lowering. Again, to suggest that LDL and LPA exert their own risks on patients independently. The takeaway here is LDL-mediated risk reduction does not eliminate LPA-mediated risk. And these are a number of studies showing that LDL and LPA are independent of each other. So which has greater risk? Is it LDL or is it LPA? So there is data to substantiate that LPA's pathogenicity on a per particle basis provides 6-fold more atherogenic than LDL. So if you see here in figure A, where the plasma concentration is 250 nanomoles, its pro-inflammatory properties through the proteasome and oxidized phospholipids, its size, its density, its Pringle repeats that are causing it to be antifibrinolytic, all lend itself to being so much more potent than LDL on a per particle basis. However, if you look at figure B here, this is more of the common folk, people who have much more LDL. And so the risk and the treatment is targeted more at LDL. But although quantity favors LDL, the potency favors LPA, sorry, on a particle basis. So this figure is simple but very powerful. At every baseline level of cardiovascular risk you see here on the x-axis, a higher LPA, we'll call this the z-axis, will exert a higher risk, right? So you see here, as your LPA levels increase, right, your risk of ASCVD also increases. And so this really reinforces the idea that LPA is a true risk enhancer and not merely some type of biomarker. And you see here in this corner, when your LPA level is at its highest and your baseline risk of ASCVD is at its highest, you are your highest risk of ASCVD. And so This figure reminds us that lowering your baseline risk, where a lot of management is targeted meaningfully through like lifetime, through like lifestyle modifications, or through LDL, can really help a patient in mitigating their risk despite the LPA being high. But again, LPA does exert its own risk. So how about screening guidelines and disparities? So what are the current screening practices? So this is I actually like this slide because it's already outdated. So as you can see here, there's all these different societies that are suggesting different ways to screen or measure for LPA. And you can see no one's really in agreement. And there's a lot of caveats and ifs and thens. And what we're seeing is that guidelines continue to evolve over time. And now, as of recent, we're kind of seeing a trend towards universal screening in LPA. So you can see here in this figure, on the left here, there's an increase incrementally in risk with increasing LPA levels. And if LPA levels are not considered, your risk might be underestimated substantially. So the European Society of Cardiology and the European Atherosclerosis Society put out a focus update in 2025 to their 2019 guidelines for management of dyslipidemia. And they now recommend, based off class 2A evidence, class 2A recommendation and level B evidence, that everyone should be considered for LPA testing. And also, this is from the focus update to the 2019 scientific statement on use of lipoprotein A in clinical practice from the National Lipid Association, who also recommend measuring LPA once in a lifetime in every adult. And LPA levels do represent a spectrum of risk rather than a threshold at a certain cut point. And as you can see, as you will learn rather, LPA levels tend to vary within different races as well. So we just can't always assume. We should just screen everyone. And also what we'll get into is more cascade screening as well and what that means. So despite these existing and emerging guidelines, screening does remain low. This study across 6 academic medical centers associated with UCLA was assessing the prevalence of LPA testing overall in those with various cardiovascular diseases and those undergoing cardiac testing. And we can see here, despite its prevalence and clinical significance, it's not tested as much. And even our study at Rutgers, we can see here, no one was really ordering lipoprotein A in April of 2024 up until August. The line here represents our intervention, which I'll talk about in a bit, but just showing baseline testing was maybe a month. And then here in March, you see the arrow, that's when the NLA put out their focus update for universal screening for LPA. So because LPA levels are highly heritable, screening relatives of affected patients can also identify patients at risk. So in this cohort of about 52,000 participants, they found about 47% of first-degree relatives and 32% of second-degree relatives of individuals with elevated LPA also had high levels of LPA. So this is a very, I think, convincing paper kind of telling you that, hey, maybe cascade screening is a high-yield strategy in targeting patients and their families or just patients at high risk of elevated LPA. How about disparities? So fortunately, those of African descent have the highest LPA levels, but are less likely to be tested than those of European ancestry. And people of lower income, who tend to have less insurance coverage, are also less likely to get testing for LPA. So just to recap, when LDL is optimized, does LPA exert a risk? Absolutely. ASCVD risk is independent of LDL. Generally, who should be screened for LPA? Everyone, once in a lifetime. And we'll talk about why in a bit. And who is most at risk? It's seen in all races, but it tends to be Black patients and those of low socioeconomic status. How about current and emerging management strategies? So far, we learned 3 things, right? LPA is more atherogenic per particle than LDL. It acts as a true ASCVD risk enhancer, yet it remains undertested despite these risks. So that brings us to our most important clinical question. Once you screen a patient, you identify them as high risk, what do we do with the level? So LPA levels are largely genetically determined, and they are not meaningfully reduced, unfortunately, by lifestyle modifications and also like statins and Zedias. And as of right now, there's really no approved LPA-specific outcome therapy yet. But we'll talk about some that are coming or on the horizon. And so management focuses on reducing overall ASCVD risk. So how do we do that? Lifestyle modification and LDL lowering cholesterol of many things. So Life Simple 7 is a cardiovascular health metric, and it involves smoking cessation, eating better, getting active, losing weight, managing your blood pressure, controlling cholesterol, reducing sugar. And even though lifestyle doesn't meaningfully lower your LPA itself, this meta-analysis done by Dr. Razavi from Emory analyzed participants without any clinical ASCVD, but achieved Life Symbol 7, whether it was poor, average, or optimal. And those, if you see here, this is your y-axis cumulative incidence of ASCVD, your x-axis is your follow-up time, and here are the different levels of LPA. And you can see people with an optimal Life Symbol 7, so basically people who were losing weight, controlling their blood pressure, had a lower incidence of ASCVD. And what's nice is that across all LPA levels, even the highest LPA level, we were still seeing that reduction. So if you have someone with high LPA and you're aggressively managing other risk factors, you can still significantly reduce their risk. Yes, there is residual risk associated with LPA, but their risk is so much better compared to someone with a poor risk factor control. And so also coronary artery calcium scoring, something that's a bit controversial in cardiology, but in this primary prevention analysis of patients from the MESA study and the Dallas Heart Study, both LPA and coronary artery calcium scores were independently associated with incident ASCVD. But when assessed together, you can see here in patients with an LPA of quintile 5, so the highest LPA levels, and very high coronary artery calcium scores above 100, we saw a risk of 4.71. And this is more supporting an additive risk profile as opposed to more synergism, again, suggesting that these are more independent of each other. So what suggests is that you can actually take both measures and better understand the patient's risk of ASCVD. And you can see here in patients with a coronary artery calcium score of 0 and lower or higher LPA levels, there really wasn't much of a hazard ratio. They all cross 1 here. So just to go a little further into this, LPA quintiles 1 through 4 are represented in the orange here, and quintile 5, the highest levels, are in blue. And we see in quintiles 1 through 4, with a coronary artery calcium score of 0, these people had the lowest risk of 10-year ASCVD risk. Whereas in the opposite corner, in the highest LPA levels and the highest coronary artery calcium scores, we see that's the highest 10-year ASCVD risk. So across this strata, LPA was still conferring greater ASCVD risk with the strongest effect, as you can see here in patients with subclinical atherosclerosis. And I want to make a point here that even though the coronary artery calcium score here was 0 and their risk was lower, it doesn't necessarily eliminate lifetime risk, right? This study was looking at 10-year risk. Elevated lipoprotein A, again, can confer risk to peripheral artery disease, ASCVD, calcific aortic stenosis, all throughout the lifetime, not just 10 years. So I want to remind you that in patients with elevated LPA, risk exists on a spectrum, and your coronary artery calcium burden can guide intensity and preventive therapy through shared decision-making with your patients. So what are our pharmacological treatment options? So here's a summary table of the different interventions that influence LPA levels. So statins have been observed to increase the LPA anywhere from 10 to 20%, but they are a cornerstone of LPA management. And there are studies suggesting that really this increase in LPA doesn't have much of an effect on the risk of the patient. Also, people with chronic disease, such as CKD or liver disease, you might see an increase in LPA, low-fat diets. Niacin also has been shown to have a dose-dependent decrease in LPA, but we don't necessarily recommend it because of the adverse effects. PCSK9 inhibitors, which we'll talk about, also exert a nice effect on LPA lowering. And apheresis is a big FDA-approved modality used to also reduce LPA, but there are also some limitations with apheresis as well. And unfortunately, exercise and weight loss do not confer any decrease or increase on LPA levels. So statins don't lower LPA. And as you know, it's reported that it may actually increase it. But again, they are a cornerstone of management because we're addressing the overall cardiovascular risk. And so in the Jupiter trial, patients stratified by LPA derived similar relative risk reduction from Crestor or rosuvastatin. So statins reduce ASCVD risk regardless of the LPA level. Supporting treatment as of right now is based on the overall cardiovascular risk and not LPA alone. But that being said, elevated LPA remains a source of residual risk despite this optimal LDL lowering. And so just to drive home this point, statins lower the LDL and total ApoB, which reduces the overall atherogenic particle burden. And there are no studies suggesting that the statin-induced LPA rise negates these benefits. So the bottom line, they're foundational, and LPA here is an additional risk factor. And an elevated LPA level should prompt intensification and not avoidance of statins. So will therapies that lower LPA improve cardiovascular outcomes? So PCSK9 inhibitors have been receiving a lot of attention, and there's evidence that suggests that they can reduce LPA anywhere from 20 to 30%. And we'll talk about the Fourier and Odyssey trials. So Fourier trial evaluated evolocumab and its reduction in LPA and the risk of cardiovascular outcomes. And this post-hoc analysis of the Fourier trial observed that evolocumab produced a very potent LDL reduction and also an LPA reduction as well. And what we're seeing with LPA reduction is that patients who tend to have higher LPA levels benefit the most. You can see here, when LPA is above the median, patients had a significant decrease in coronary heart disease, death, MI, urgent coronary revasc, and here the same thing when LPA was above 120, compared to patients who were below the median and below 120. So is it LDL or LPA lowering that contributes to improved outcomes when we're using these PCSK9 inhibitors? So in this analysis of the Odyssey outcomes, alirocumab lowered LPA about 23%, and they both dropped LDL, seen here in orange, and lipoprotein A in green. And so we're trying to figure out, okay, how much did LPA actually contribute to decreasing this risk? And so what we see here in the 75th percentile of people with LPA levels, so much higher LPA levels, LPA lowering contributed about a quarter of the risk reduction compared to LDL. And so we're going further into this, and the field is now waiting on dedicated LPA outcome trials, so more aggressive LPA targeting, and seeing, such as the phase 3 Horizon trial, testing pelacarsen, seeing if LPA lowering will actually reduce major cardiovascular events. And so looking into the future, there are emerging agents for LPA lowering. We have here the antisense oligonucleotides, therapies like pelacarsen. These are single-stranded nucleotides that are linked to a sugar and basically allow uptake by hepatocytes. And in there, they bind LPA mRNA, and RNase comes in and degrades these molecules, effectively reducing ApoA. Then you have the small interfering RNAs, and these are like drugs like olpasiran and lepodisiran, again entering hepatocytes, load into the RISC complex, and cleave LPA mRNA, again silencing ApoA synthesis. And then lastly, we have our small molecule inhibitors like muvalaplin, which disrupts LPA particle assembly, preventing the binding of ApoA to ApoB, blocking formation of the LPA complex. And here's an overview slide of the different medications we just talked about and where they are in their clinical trials. We have pelacarsen in its phase 3 study, olpasiran as well in a phase 3. So a very exciting year for LPA and its therapies. So looking at the alpaca trial, this is a study of lepodisiran in participants with elevated LPA. And we found in a phase 2b study, in patients with elevated LPA, lepodisiran potently reduced LPA by up to 95%. And there was really no serious adverse events with the exception of some injection site reactions and some elevations in AST and ALT. But again, ongoing studies will determine if this drug is clinically safe, but I think it's rather promising. Also, the Ocean A dose trial. This is a phase 2 randomized placebo-controlled trial of the siRNA olpasiran. And in these patients with established ASCVD already on maximal lipid therapy with a mean LPA of 260, they were given olpasiran. And you can see here, this gray line This is your placebo, so they did not receive olpasiran. And these patients here are receiving olpasiran in different doses. And we see in the higher doses of olpasiran a near 95 to 100% reduction in LPA, which is quite impressive. So again, still waiting for the clinical safety of these medications, because what benefit does lowering LPA to an extremely low level confer on our patients? And then lastly, the very well-known Horizon trial. So pelacarsen has been shown in phase 2 randomized trials to produce a large dose-dependent reduction in LPA, up to 80%. And so we're waiting for this phase 3 trial to determine whether LPA lowering translates into fewer cardiovascular events, which is very exciting. However, I guess good news is that the results have been delayed due to lower than expected event rates. And so talking about all this management, I also want to get into prevention. And aspirin might be making a resurgence. So given LPA is prothrombotic, the thought is aspirin might have some benefit. So in the well-known Esprit trial, they took healthy adults above 70 and gave them either aspirin or placebo. And unfortunately, they didn't find no overall cardiovascular benefit, and if anything, a higher bleeding risk. But this genetic analysis of the Esprit trial evaluated about 12,000 patients, looking really at the LPA-related genetic risk and seeing that modifies aspirin prevention in primary care. And overall, they found that aspirin reduced MACE by only 1.7 events over 1,000 years. But when they stratified by genotype, so looking at people with the RS3798220 carrier, what do they find? They found a reduction in MACE by 11.4 events per 1,000 years. And that was not offset by bleeding risk. Bleeding risk was only 3.3 events. So your net was 8.1 events per 1,000 person years. But limitations do exist with this study, as these patients were elderly, and this was looking more at the genome. It wasn't actually patients with measured LPA levels receiving aspirin in real time, and they weren't as young. So something to consider. But a lot of new studies and letters are coming out to go further into aspirin and its role in primary prevention. And I briefly want to touch on LPA plasmapheresis. So this is an FDA-approved therapy for treating refractory high LDL and LPA, and usually in children and adults with FH as well. I like to think of this as more like dialysis for cardiology patients, basically removing lipoproteins from the blood. Typically it's done every week or 2 weeks, but there's a rebound effect where these lipoproteins do increase in production. But I've been reading online that it does lower MACE by 75 to 85%. But there are limitations involved. It's resource intensive. There could be an access issue as well. But this could serve as a bridge therapy for very high-risk patients as we await these LPA-lowering therapies in phase 3 clinical trials. So lastly, let's talk about implementation science and quality improvement. What did we do at Rutgers? So how to promote LPA testing in real practice. So again, back to this figure. All these different societies saying different things. We are trending more towards universal testing, but the philosophy we adopted was actually from Dr. Bhatia at ACC, where he mentioned, if you have all of these nuances, you're going to be doing a bad job screening patients. Why not screen everyone? You will miss less people. So we went off the NLA focus update, which was to screen everybody for lipoprotein A. And before we even get into it, we should talk about what affects LPA levels. So I know we touched on this earlier, but it is important that when we screen patients, we don't always have to retest. If anything, at Rutgers, we don't recommend rescreening unless they're more in the gray zone or there is a very, major physiologic change. Let's say you have CKD, they're always high, or they're pregnant. LPA can be an acute phase reactant. Maybe very niche scenarios you can consider retesting, but most of the time we don't suggest retesting patients. So what do we do? So lipoprotein A wasn't largely tested in the internal medicine clinic or department across Rutgers. So after the NLA put out their guideline recommendations on universal testing, we went into action a month later in April. So we started educational flyers. We put them all over the desks in the clinics. We sent out biweekly emails highlighting what LPA was. We even included flyers like this, and I'll go more into what else we offered. We had a lot of Q&As. We did a lot of educational sessions, also a lot of word of mouth and a lot of grassroots teaching. And so we sent out this flyer in addition to biweekly emails for several months to all the residents on clinic and also attendings as well. And also, we also shared this clinician infographic. So coming from the National Lipid Association, on their website, they do have an infographic for residents, attendings, clinicians to read up on, on LPA screening. And this is a very concise and impactful infographic if you're trying to get someone to read more about LPA and learn more about it. And also, you have to educate the patient. At the end of the day, this is all about the patient. So taking time to educate your patients, giving them this flyer to also helped us communicate the importance of what LPA was, because a lot of patients didn't understand what LPA was. They already have a cholesterol panel. Why do they need this other biomarker? And so in our first study at the Veterans Affairs Hospital, we started screening patients in April. So lipoprotein A was not an order that existed in the EMR at the Veterans Affairs Hospital. It was never a thing. It was not ordered much or truthfully at all. And so within a month, we got that test available in April. And from April to August, we told nobody about the LPA order test. It was available in the lipid panel order set, but we told nobody about it. And so we were seeing maybe 1 or 2 tests a month. But then August came and we hit our educational intervention. We did lectures, emails, flyers, and we can see a notable increase in testing per month, where we're hitting about 50 to 60 a month. And this is all in 2024. And so in our pre-intervention phase, for 4 months, only 8 people ordered. And then after our intervention, we had about 190 people ordered, spread across attendings, residents, and also NPs as well. And so our big outcomes were we increased screening by 24-fold. And weirdly enough, despite the global distribution being 1 in 5, we identified 43% of patients were high risk. And also, based off the NLA guidelines, I developed an algorithm to give to providers so they can refer to this when they're managing their patients. When do we screen patients? When do we retest? How do we identify patients as high risk or low risk? And if they're high risk or low risk, what medications do I start? And so this is a good resource for our providers in managing their patients. And so we did a follow-up study for the first 6 months and seeing how our providers responded to our educational intervention. And we saw in the first 6 months, 3/4 of providers just about address this elevated LPA level. And you can see here in the black text, this is the mean LPA level. So about 41% of providers intensified therapy, and the mean LPA was about 190. 31% maintained. A lot of them were already on statins, so they just kept them at statins. About 14% just recommended lifestyle modifications. No intervention was done in 10%, and then some patients declined. And so given the success at the VA, which not to mention, not only started at one hospital, I unknowingly didn't realize that this spread across all VA sites throughout New Jersey. We have 2 hospitals in New Jersey that are Veterans Affairs, but also about 10 to 12 healthcare sites affiliated with the LPA. So now everyone across New Jersey at the VA is ordering LPA. And we have so much data. We have about 14 months of data to look through to see what providers are doing with their patients, how they're managing them, and also their screening practices, which seems to be increasing every month. And so given the success, we extended it to University Hospital, our primary teaching hospital, and what we call the Achilles QI, which is Advancing Cardiovascular Health Initiative through launch of lipoprotein A education and screening. And so this internal medicine clinic serves a very diverse and underprivileged population. About 3/4 of patients who had increased levels of LPA were Black, 20% were Hispanic, and the rest were other or white. And so how did our academic counterparts manage their patients? So we see here with a mean of 197, 31% of providers initiated therapy or intensified therapy. 14% maintained it. These guys were definitely a little higher. About 18%, we still had to, they were still pending follow-up. 6% of patients declined, and only 4% had lifestyle counseling. This is all within the first couple of months of screening at University Hospital. And we can see here there was some residual screening done from our initiative at the VA. But when we intervened, we can see here a meaningful increase in screening. And I anticipate the December dip might have been due to Christmas, which is always a good thing. But we are continuing to monitor their screening practices, and it seems like they are very involved with screening this underprivileged population and very diverse population as well. And so the question I got, say University Hospital, is these patients sometimes have to pay out of pocket, and they aren't from the most, I guess, wealthy backgrounds. So how do these people afford LPA testing if they really need it? So the Family Heart Foundation does offer LPA testing free of charge, and we do encourage patients to get that done and bring their results to us if they can't afford it or if their insurance doesn't cover it. But most of the time, the insurance does cover it, or they can order through Quest Diagnostics. I'm almost positive, I think a chest X-ray costs more than an LPA test, which is always good. But unfortunately, with patients who may not have insurance coverage but really want to get this test done, we do encourage them to go through Quest Diagnostics to get it done too. And so achievements of our studies is that we proved LPA screening can scale through educational initiatives. We had a 24-fold increase in testing at the VA and over a 250% increase in screening in our academic clinic. And so this detection translated into real preventive management. As you can see here through our different cohorts, in our follow-up study, about half of our veteran population had elevated LPA levels, and 3/4 of them were being managed some way within 6 months, 41% of which had therapy intensified. And then our academic cohort, 42% had elevated LPA. Again, both populations more than double the global distribution, and about half of them are receiving active lipid-lowering therapy. So we reach populations historically left behind and that increased risk. And I'm hoping this serves as a model for precision preventive cardiology. I think this one-size-fits-all approach is kind of dying, and I think lipoprotein A offers a nice modality to be more precise in the care of your patients and not just blindly suggesting X, Y, and Z as management. And some limiting factors we ran into were some system barriers. So not everyone was familiar with lipoprotein A. And also with our demographic, the average comorbidity might be 4 or 5, even more. And so there are always competing clinical priorities in a 30-minute to 60-minute healthcare visit. Also, our EMR prompts didn't really have any automated reflex testings like in the CPRS of the VA. It's a little more outdated. And also, there are lipid metrics like LDL, HDL. And some providers might say, hey, these are low. Why go for the LPA? Which kind of serves to my next point, these cognitive barriers, right? If LPA is non-modifiable, why act on it? And they also, some people citing, guidelines aren't universal. If no one can agree on this, why even test for this? Some structural barriers, again, the EMR integration. It took me about 1 year to get at University Hospital. I called them, I think, every week for a year. And we finally got it done in the hospital, whereas the VA took me less than a month. Some insurance coverage, again, this is always a barrier for patients, especially low socioeconomic status patients. There are no approved LPA lowering therapies, which is a bit of an issue because when these other new medications eventually get approved, how can my patients from low socioeconomic status neighborhoods afford these medications? Again, more of a health equity question. And also, lastly, a lack of infrastructure for cascade family screening, something that we want to start at Rutgers and something that I'll have to build while I'm there. So future directions, we want to track the addition of these new medications, the PCSK9 inhibitors, maybe referrals to cardiology clinic, maybe developing an EMR flag saying, hey, your patient's LPA is above 50, conferring a risk for ASCVD. And right now, we're creating a large registry of LPA levels, the phenotypes, the event rates, seeing maybe any correlations or associations in our population and how we can intervene meaningfully. And also, going into reverse cascade screening, identifying patients who are at risk and identifying their family members who are also at risk. And so in conclusion, we highly recommend measuring LPA at least once in all adults, considering LPA as an ASCVD risk enhancer and using therapies that may benefit patients with high cardiovascular disease risk, and also being mindful that targeted therapies appear promising and are in process. And so having your patients with elevated LPA levels and having these baselines already can help move the discussion forward when these new therapies come. These are my acknowledgements, and this is my contact information. Thank you so much for having me. I am open and welcome to answering any questions anyone may have.
Thank you, Dr. Radfar. I think that was just a really well prepared and delivered presentation. So congratulations, fantastic. And we've had some great questions coming in through the Q&A, so we can start diving into those. One of them, just for everyone's kind of knowledge and awareness, was the first question that I already typed an answer to in the chat was about the age at which to start LPA screening. And as you mentioned, the NLA has a focused update out. I linked to it in my answer, and it's also in the webinar chat, that NLA update. But they basically say that all adults should have LPA tested, and that begins at age 18. And then for youth who are below age 18, selective screening of LPA is recommended in high-risk patients who have clinically suspected or genetically confirmed FH, ischemic stroke of unknown cause, first-degree relatives with a history of premature ASCVD, or first-degree relatives with elevated LPA. So all adults 18 above, selective screening in youth. We have some other great questions I think we can dive into. The first one is, oh, and thank you to Orna Reagan for that first question about age. So we have an anonymous question about evolocumab. You mentioned how it does reduce LPA 20-30%. And the question is about the Fourier trial supporting a decrease in cardiac events. And of course, more recently, we also have the Vesalius CV trial that showed in high-risk primary prevention patients reduction in events as well as mortality with evolocumab. So the question is, why is it not recommended for primary prevention in someone with significantly elevated LPA in 2026? I have some thoughts on this, but curious what you think, Dr. Radfar.
Oh, that's a great question. I think we're still waiting on, again, like the outcomes more. If we target LPA reduction, what benefit does that confer? I think we're still waiting for the Horizon trial to tell us that. So as of right now, it may not be in primary prevention, but I'll defer to Dr. Martin.
That's a critical point, I think. Yeah, you're right. I mean, we're all expecting to see that reduction in events, improved cardiovascular outcomes with LPA reduction, but it needs to be definitively proven. And so we'll hopefully have that result very soon. And obviously, there's other considerations when it comes to PCSK9 inhibitors. They were developed for LDL lowering. That's what they're approved based on. There's cost constraints given the expense of these medicines. So I think we need more data, but there's practical considerations in terms of using them for something that was not necessarily the primary way that these medicines were developed. And even though there's post hoc analyses that are supportive, it just can't justify widespread use in the primary prevention setting. That being said, I think this is a group where cardiac imaging can be very helpful. Many people in the Vesalius trial had very high coronary artery calcium scores. And so that's where if you could demonstrate that this is not like a lower risk primary prevention person, but this is someone with a coronary calcium score above 300, placing them in a secondary prevention risk category, it may be help with justification for more proactive therapy, including PCSK9 inhibition, not purely for LPA lowering, but for LPA lowering in addition to more aggressive LDL lowering. Let's move on to the next question. So from Jamie Shockley, thank you for the question. And I think this is specifically about your local work, Dr. Radfar, and congratulations on that because it's really fantastic.
Okay.
So during your trial, was therapy intensification as a result of LPA screening largely LDL lowering therapy intensification? And if so, did you quantify a mean reduction in the patients with intensification?
It's a great question. So we had patients already with like lipid panels in the LPA order, really, I guess, kick providers into intensifying therapy. It was more just statins or Zetia, nothing really else. And then you asked if so, did you quantify mean reduction in LDL seen? We didn't. We didn't follow up with lipid panels. It was more just, hey, the LPA is very high. It confers some type of risk. Let's start statin or Zetia. We didn't look at it wasn't really the LDL risk. It was more so the LPA.
Hmm. Okay. Um, so, and it's great. Like it does seem like this is an ongoing work for you. So, you're going to continue to learn, more around potentially some of the questions that are coming in. But then the next question is from a anonymous attendee. After implementation, did you track if there were increased referrals to cardiology, endocrinology, lipid clinics? It sounded like that is part of your ongoing work, but have you tracked already any data on referrals to address high LPA in these specialty clinics, or are they mostly managed by primary care?
Yeah, so this is all in a primary care setting because we were assuming the cardiologists are already aware of lipoprotein A, they're already managing their patients. But that's actually in our next study looking at referrals to more specialized clinics. Unfortunately, we don't have a lipidology clinic, dedicated lipidology clinic at Rutgers, but this is catching steam and there is a preventive clinic, and that's something we're keeping an eye on and seeing how providers are managing their patients. But a lot of this was largely through the Department of Internal Medicine.
Great. Um, We're doing well on time, so definitely, folks, feel free to bring in additional questions. We have a few more here. So, from an anonymous attendee, we have a 70-year-old woman with an LDL cholesterol of 160. LPA is 90 milligrams per deciliter, and the coronary calcium score is 0. Would you treat? And if not, then how would you follow this patient?
Yeah, that's a great question. So, medicine is great because we say we practice medicine, so everyone does it a little differently. And so seeing the LPA here is above 50 it definitely places her at an increased risk. And also one thing you have to realize is that elevated LPA also confers a risk for aortic stenosis, which affects these elderly patients. So I actually do screen them. And it depends, right? Like what is their lifespan? Will it change by management? If they're in a unfortunately pass within a couple of years, does it confer a benefit? Maybe not. But if you think they have a favorable profile, maybe I would start a statin. It might help them out, maybe prevent uh, development of aortic stenosis or coronary events. So I would still start it.
Yeah, I mean, it does seem like this case would come down to shared decision making with the
Yeah,
patient. They fall in a category where they don't have ASCVD. As far as we know from the question stem here, they don't have diabetes, and their LDL is moderately elevated, but not severely elevated. So they fall into the category where you would calculate 10-year risk. Current guidelines, that's using the pooled cohort equations, but of course we now have the prevent equations, and those are in the process of being integrated into the guidelines. But it does seem like it'd be a good idea to do the 10-year risk calculation. It's nice that we already know the coronary calcium score, but that it doesn't mean that you would necessarily avoid treatment. As you indicated, you would tend to favor treatment. So I would be interested to see. I mean, the risk calculations are driven to a large extent by age, and this woman is 70 years old. And that LPA you can consider as a risk enhancing
yeah,
factor. By the way, in terms of units, we are moving towards a preference of nanomole per liter units rather than milligram per deciliter. But clearly, that's a high level.
yeah.
So it certainly could be very reasonable to proactively start statin therapy despite the calcium score of 0, to be proactive given the LDL, the older age, the high LPA being a risk enhancing factor. I agree. Um, okay, thank you for that question. The next one we have is from Elisa Winningham. Great presentation, Dr. Radfar. Would you be willing to share your presentation slides?
Yeah, absolutely. I would love to.
Great. Thank you for that question, Alyssa Winningham. We'll get those out. I guess um, perhaps the NLA could maybe email that to all attendees. I'll let the NLA maybe like weigh in the chat channel, perhaps. Sheila Stadler is asking, I appreciate you sharing your flow chart on how to address elevated LPA levels. The question I get more frequently is what to do for primary prevention patients with lower 10-year risk, like less than 5% with an elevated LPA and normal lipids. I know we want to control other CV risk factors as discussed, but would you also start a statin in this type of patient? So this interesting question that I think has a little bit of relation to the one we just addressed. So of the patient case.
Yeah, that's a great question. It's a nuanced question, I would say, because you have to consider their comorbidities, and their age, and depending on on how high the elevated LPA is. But yeah, again, you have to think elevated LPA confers a lifetime risk. So if we can get ahead of that, I think it might be favorable. I guess like how high, moderate, low intensity statin, I would maybe go low intensity or moderate intensity. But looking at this patient, yeah, it depends, I guess, more nuance on their age, their comorbidities, and whatnot. But also, you don't even have to start a statin. You can also just, again, looking at Life Simple 7, controlling the blood pressure, exercise regimen, losing weight. You can also go aggressive in that way too.
Yeah. Good points. Good points. So it certainly would be an individualized decision. Depends, like you said, how elevated is LPA, how normal are the lipids. I mean, I've seen people who have really high LPA that have an LDL that's below 70, right? So you do start to then wonder, what are if it's that type of situation and their 10-year risk is really low, and let's say you even get plaque imaging data and there's no plaque, that would push me away to feeling like a strong need to start statin therapy. But if the pendulum was swinging the other way in terms of some of those factors, it could be reasonable to proactively start a statin. And I think this less than 5%, the interpretation of 10-year risk is going to be evolving here as we move from pool cohort equations to more use of prevent equations. So, and there's about a 50% difference in those equations with the prevent coming out lower. So I think we'll also have to shift our mindsets in terms of what we consider truly low risk based on the use of different equations. And I do have an update from the NLA that's working on figuring out how to best share slides, but certainly thank Dr. Radfar for his willingness to do so. Um, Okay, let's move on to another question from anonymous attendee. What about strategies for patients in their 20s with low LDL, so 50s to 60s, very fit, LPA of 140, 150 milligrams per deciliter, so a very high LPA, otherwise low risk, no premature family history?
Yeah, that's a great question. I think given, the LDL is controlled, the patient's age, I would again go more for like modifiable risk factors like Life Simple 7. Patients 20, cholesterols are normal. I think in a no premature family history, I think it's okay to go aggressive and more towards lifestyle management, but that's just my practice. I'm not sure what Dr. Martin does in his clinic.
Yeah, I would tend to agree with you, especially given like assuming that there's truly like no other risk factors and LDL's already in the 50s or so, like yeah, I would focus probably more on lifestyle. Think about at a later age doing athero imaging, like they're too young for a coronary artery calcium score. Before that age, a carotid ultrasound could be considered if you have like a really experienced local lab, but that's not something that's strictly kind of evidence-based guideline recommended. Um, Thank you for that question. Okay, we have another question from Emily Colson. Do you have an LDL goal for patients who have, I assume this means elevated LPA? I have heard that just going to the 30 lower than what would be otherwise your goal. Thank you for that question. So, yeah, so do you have you heard of that as well? Do you use that, Dr. Radfar, in your practice, this idea of bumping their LDL goal down to the next step, so 30 milligrams per deciliter lower if someone has high LPA?
Yeah, I've heard that actually at different conferences too, people being very aggressive with LDL. I haven't gotten there with my patients yet. I
Yeah.
try to like go below 70 if they're very high, but I haven't had anyone yet at 30 just yet because we're still following up. But I'll let you know.
Yeah. Yeah. I'm not sure this has been solidly kind of
Yeah.
cemented in expert recommendations and guidelines, but it is something an idea that comes up quite a bit and seems reasonable to say, given LPA is this risk enhancing factor, I'm going to be more proactive. And it could be going from the 100 to 70 goal or the 70 to less than 55 goal, depending on the clinical context. So, Thank you for that question, Emily Colson. And we will move on. Alyssa Winningham has another question. Could you elaborate further on the LPA flag that was created, criteria for which patients the alert fires, which provider specialties it fires for, and are there any action items presented to the provider from the alert?
Yeah, this is something we want to develop. And so on Epic, for example, you can create a flag for patients if their LPA is above, let's say, 50. And again, this is more for this was in the internal medicine department, so we would try to include this in that department. But more, I think you have to talk to IT at your institution and see if they can set that up for you. That I'm not too sure how to do on my own. I'll be honest with you. But as far as criteria, it's more just like, hey, high LPA, consider managing this patient. Very simple, very sweet. That way you can kind of take a look, talk to the patients, and see how you can intervene.
Yeah. And I think it you should be congratulated on the amount of perseverance it takes. It sounds like you had to like for a year where I think you were calling your lab to
Yeah,
get this going. So to work with your clinical chemistry lab, but also your IT folks to kind of build a program like this locally, it takes a lot of effort and perseverance over, good period of time. So I think you should be congratulated on that.
thank you.
I know from our local efforts, it can be a real haul. Okay, we have a question. Thank you again, Alyssa, for that question. Joel Goose has a question. Do we know if elevated LPA is secondary to increased production or decreased degradation?
Hmm. So it depends on the state. Like with kidney disease, you might have decreased clearance, might increase your LPA. In liver disease, you might have, again, parenchymal damage that might decrease production of LPA. I think it depends more on on the pathology and what's going on, I would say. Yeah, it's a spectrum. So
Right.
many things that are going on.
Right, right. And some of these kind of secondary factors can have effects on LPA, and they could perhaps have upward of maybe 25% biologic variation over time. But largely, part of why it's being recommended to try to focus on a test at least once, but not necessarily repeating it, extensively, is because it's so strongly genetically determined. Um, this is amazing, the great questions we have coming in. Thank you to everyone for your engagement. We have a few minutes left. We're going to try to get through the rest. So Ada Roman is asking, there's emerging data on women having an increase in LPA after menopause. Are there any recommendations on when to repeat LPA levels in this group? Do we repeat LPA at 1 year, 5 years, 10 years post menopause?
So I don't remember any guidelines that recommend repeat screening for menopause. Do you know any, Dr. Martin?
Yeah, I don't know that there's definitive recommendations here. It is a really interesting question, and I'll say, this may be a question that would be best directed to someone who is like a real true expert in women's health. But my clinical sense would be that we wouldn't automatically repeat it at any of these time points. But basically, if you had someone that was kind of on the borderline zone, especially when we get to the point of having drugs that are where the eligibility is based on certain thresholds, it could be very reasonable to do if someone was close to the threshold but not quite there, to repeat a level later on. But I think that's a concept that you may also apply to patients outside of menopause, but especially in someone in the post-menopause uh, setting. Okay, let's keep going. Thank you for that question. We have Salima Al Makbali. Thank you for the wonderful presentation. Do you advise including the LPA test in the lipid profile for high-risk patients?
Absolutely. That's what we did at the VA. We have it part of the lipid panel set. You get your LDL, HDL, triglyceride, and your LPA. That way you get a full spectrum of risk. I absolutely do recommend it. Again, because this is an ASCVD risk enhancer. So even if your patients have normal or borderline LDL levels, that's when
Mhm.
you can intervene. Actually, my borderline patients is when I intervene and I get an LPA. So I definitely
Great.
recommend getting it. Yep.
Awesome. Okay. And then we'll take one final question here. It looks like we got through them all from an anonymous attendee. Thoughts on repeating levels after major medication changes, since we probably did not understand all the medicines that may affect levels. I think certainly we know that PCSK9 inhibitors have a lowering of LPA or if someone goes on apheresis. But so it could be reasonable of obviously to follow up a level in those settings. Any other medicines that would make you, want to follow up a level?
Maybe like some type of hormone replacement therapies,
Hmm.
but not typical in my practice with the veterans as of yet.
Great, great. Well, this has been fantastic. That's all the time we have for today. If we didn't get to your specific question, we will do our best to follow up via email. But we did get through all the questions in the chat that I saw. And a huge thank you to Dr. Navid Radfar for sharing your expertise. And that was just a fantastic presentation. And thanks to everyone for your active participation. A recording of this webcast will be made available on the website within about a week. And I know the LNLA staff is working to figure out how to get the slides out. So thanks again to everybody. Have a great rest of your day.